So to start off with this session, I would like to request the chair, Dr. Praveen Gedam, to briefly talk about why we at NHA or in general think teleconsultation is going to play an important role in improving healthcare delivery in India. In fact, one of the major use cases that we at NHA are looking at for the adoption of UHI is teleconsultation. So I would request Dr. Gedam to briefly talk about what his views are about teleconsultation and its role in improving healthcare in the country.
Thank you very much, Kiran. I think this group and we all sitting in Bangalore are one of the few fortunate people who have reasonable access to healthcare. But think of a poor villager in some far-flung remote areas like Chhattisgarh or Jharkhand, some tribal village out there. So how can he have that ease of access to the doctor? And in the absence of that, he is forced to go to a quack or try home remedy. So I think this bridging of the gap between different parts of India is one of the key outcome that impact that teleconsultation is going to have. Now there are lots of regulatory and technical challenges, I understand, and we have ironed out a lot of regulatory challenges in last couple of years, particularly during COVID. Technical challenges still remain, but with thanks to the success of solutions like eSanjeevani or several other private teleconsultation apps, we are seeing now increasing adoption of teleconsultation. Even commonly used apps such as WhatsApp video calls, they are now being used for teleconsultation, but there are a lot of add-on features which are required. There are a lot of legalities which and then payment issues which are involved into it. I mean, you are going to a doctor, let us say you have visited a doctor and during follow-up you say, okay, this is my blood report and what do I do now? And you generally, we are not in a position to pay during that. So we should also have that mechanism to enable payment, redress any grievances or any other two-party issue. So all these things are there, and I think this is one area where which we look forward to as one of the early outcome of the digital health mission.
Thank you, sir. Dr. Haleema, you have been a practitioner and you have worked extensively on teleconsultation. It would be great to actually listen to your experience and what you feel are the drivers, impediments or blockages in terms of policy and regulatory mechanisms and any other things that you feel you have encountered in your vast experience in teleconsulting.
Okay. Hello, everyone. First of all, thank you, NHA, for this opportunity. Such a pleasure or honor to be here, one among the dais people over here. Well, let us talk about teleconsultation and telemedicine. How many of us here are aware of what exactly a teleconsultation should be like and what it actually helps and how it actually should be carried out? I'm sure, even if I have my colleagues in here, physicians, diabetologists, so on and so forth, are not aware about the protocols a teleconsultation involves. They're not aware of how exactly a teleconsultation should take place. As the chair rightly mentioned, the use of WhatsApp, this has been used quite often, and I feel it should be discouraged like in a proper way because we do not have any legalities to support that. We don't have an EMR, we don't have an EHR, we don't have anything in the WhatsApp which will actually help me store the message or store the call for long duration for legality purpose. The way that we can actually increase the adoption for teleconsultation with my colleagues or with the patients at large is by educating them. We will have to carry out programs like this, wherein we are telling our colleagues or my patients or people who are not aware about telemedicine, the details about what exactly happens in a teleconsultation call, how ideally it's carried out, and what exactly is the outcome of it. I think if we give the data about the outcome of the benefit of the teleconsultation to patients, which has actually been seamless, that would actually go a long way. To be precise, during the COVID-19 pandemic, I personally have seen around 7,000 patients out the way on an honorary basis. this particular thing would not have been possible without teleconsultation. If I would have gone ahead for treating patient in person, maybe I would have seen maybe 5 per day or 10 per day, or maybe if I stretch myself 15 per day. And possibly seeing 100 patients per day would actually be totally, I would say totally impractical if I'm going in person. Whereas in the COVID wave during this particular, this pandemic phase which happened, we were triaging and treating around 100 patients per day on a telemedicine basis. So increasing adoption of telemedicine with the practitioners will go a long way in helping the patients out there to get the proper treatment on time. The right way of doing it, educating the doctors about the awareness of telemedicine and the benefits of it, and the patients alike. I would recommend to use social media, and of course, we can go ahead creating seminars or webinars like this for encouraging education or knowing more about telemedicine. Thank you so much.
Thank you, Dr. Haleema. In fact, following up again on this topic, one of the things that comes up when we in India go to a doctor, and the expectation that we have is he spends some time with us, the doctor, he or she, and there is a kind of a physical interaction that happens. So this is an expectation. And sometimes teleconsultation may or may not be able to provide that kind of an experience. So are there any specific services that we provide, a physician provides to a doctor, that are more suited for teleconsultation versus those that may not be suited? And if we identify and target those, do you think that would help us adopt teleconsultation in a better way across the country?
Yes, definitely it would help us adopt in a better way. As the chair and the moderator rightly mentioned, that the human touch is what is actually, Dr. Gedam mentioned that the human touch is what is lost in teleconsultation. The reason why the patients do not prefer or opt for a physical consultation is the patient-doctor relationship or the patient-doctor touch, which is not there in teleconsultation. But as I mentioned even earlier, that if we follow a certain protocol in the telemedicine consultation, if we actually streamline the consultation in a proper way, even that can be achieved. We as consultants and we as physicians should not be talking to the doctor, to the patient in an overtly friendly way or talk like a normal call. We should actually have a professional code of conduct during our teleconsultation and formalize the call to keep that touch of a doctor and a patient alive. So, and we can use medium like digital stethoscope. We have so many other options which are coming up now technically to bridge the gap between the doctor and the patient virtually and physically. So I think the proper use of otoscope, the dermoscope, the digital stethoscope would help a long way in basically establishing this particular relationship and this consultation to be in a seamless way, and to in fact give the same experience as an in-person or live consultation would give. So I would recommend my doctors to basically know about the protocols, follow the protocols in every particular call that you make. The call can be because of a simple thing. I could get a call asking the patient asking me about the vaccination. Maybe there could be someone who can ask me, is the vaccination needed? I've taken my second dose, third dose required. Even this call should not be just told yes and we should not disconnect the call. That is not the protocol. We will have to go by the protocol of identifying the patient in the name, age, going in depth about the patient allergy, about the family history, about the previous history, everything in detail for the process to be acceptable with the patient and with everyone alike. So I think following a proper protocol will help this in a long way. Thank you.
Great. Dr. Gaur Sunder, I would ask this question to you. Are there, I mean, as we can see from what Dr. Haleema has said, it looks like we also need certain technology enablers for teleconsultation to be more successful and more acceptable. Can you please, with your experience at NRCeS and the kind of work you're doing, would you be able to throw some light on what kind of technology enablers are required or are already available that one can make use of in teleconsultation?
From our past experience, we know that when teleconsultation need itself arises, there are two approaches to it. One of is what you will call as data-driven consultation, where the patient or a presenting physician is essentially providing a bunch of data already to the specialist on the other side or the doctor on the other side. And the second one is where it arises on a need basis, where suddenly there is something going on, or it is the first interaction where the patient just wants to present a bunch of symptoms initially and wants to know whether which medicine to take, or as a second opinion. So this may or may not be data driven as such. When you talk about data drivenness, you know that traditionally the telemedicine could have been done in a very disjointed manner, in the sense that people could have sent email and the doctor would have just looked at the data and returned. But obviously what Dr. Haleema was referring to, the idea of patient interactivity with the doctor or the touch factor would have been missing. In the recent time, there has been a lot of focus on how to use telemedicine for presenting data in real time or in near real time, at least to the doctor. Sometimes using some of the devices, so many devices now which are coming, electronic devices in medical diagnosis, symptom taking, and other parameters recording, are increasingly becoming digital, which is one of the great things to happen. They are not only miniaturizing, they're also digitizing. So these systems, where earlier somebody had to look at the data and feed it into a system or provide it, and there was a lot of possibility of error or then summarization of the data. Now it is being done by system, which is a great thing to happen. The other thing is obviously where the telepresence becomes more and more viable, in the sense that doctors can not only see you immediately, but also with the advent of full HD cameras and things like that, they can also, dermatology is one of the very recently coming up specialty in telemedicine, whereas it wouldn't have been possible a couple of years back. So obviously, like any other stream of health, it will require that the progress happens on several fronts. One of them is what Dr. Haleema is talking about, is education side, the medicine side, the doctor side, yeah, our ability to correctly even diagnose it remotely without even having the first doctor to look at it. That itself, so use of an AI system integrated into it, some sort of analyzer where patients can directly input some initial symptoms, and the system itself prompts additional queries and questions which can be later shown to the doctor. So there's a lot of areas in telemedicine still require a bit of maturing, a bit of introduction, and with the advent of AI, newer electronic systems, etc., I think it's anyway set to progress further from that point onwards.
Great, thank you. In fact, one of the points that you have raised and follows the data-driven methodology that you talked about actually requires sharing a lot of data between the patient and the doctor. So we know you work at NRCeS, where you are the custodian of all the FHIR standards and SNOMED CT standards, etc. Can you please also describe about the kind of work you're doing in creating these electronic creating that environment or creating those standards which can actually help in easy transmission of data from patient to the doctor or doctor to doctor?
Yeah, so I will just point everybody to your presentation, your slide, where you talked about major areas of standardization when it comes to actually presenting a case. So there's a lot of technology, but other than technology, one of them is the transmission standards. How do you ensure that? And when I say transmission standard, I don't really mean the lower down. I'm not talking about TCP, IP, and HTTPS kind of standard. I'm talking about how do what is the interface of transmission, and therefore the APIs, or the backend service where a known set of function is already defined in the system, and I can simply call them in order to send the data, which earlier was not possible because I had to understand a lot of internal details in order to even transmit data from one system to another. The second one being the structural set of standards, where FHIR is obviously playing a part role. And in telemedicine and in any other health system, we are so far with NHA and industry body associations experts have already identified about 7 types of records which can be digitized into a standardized format. So wellness is there, prescription is there, diagnostic report is there, OP note is there, and things like that, where a standard has been created in terms of attributes, and their profiling has been done in the sense that what will be mandatory, what can be skipped, at what place, what value should appear. And that standardizes and provides a very disjointed and a mechanism to understand how I should basically package my data in order to send it to you without having to ever having known you or talk to you or discussed anything with you. And the last one, the semantics, where the meaning gets transferred, where the SNOMED, the ICD, and the LOINC will already playing a very pivotal role around the world. And in terms of making things simpler, what we have been doing and telemedicine, it has great use, is we are using language translation along with terminology. So we identified about close to 500 terms which doctors use in their advice in prescription. And we are already providing it a Hindi of it. And the idea is that we'll soon provide Marathi, Tamil, Gujarati, and several other language. The benefit of it is that when a doctor writes that medicine A, you take it twice a day, the prescription can simply be printed in Hindi. With the terminology support, you don't actually require a translation system in the backend. So it is just a press of a button and it says, this medicine, din mein 2 baar khane ke baad.
Right.
Or you ask the patient say Marathi and you simply select Marathi and print it. So it becomes rather a back-end mundane job where you're not even worried about what is the accuracy of the translation that comes out. We know that most of the translations are not very accurate, but this is terminology-driven, translated, pre-translated values.
Correct.
So these are in a term, helpful in many places, including in telemedicine. It has a great role because vernacular is one of the major reason why. I think it's going to be one of the major success drivers for telemedicine in coming years. People's ability to use medical systems in their own language.
Great, thank you. In fact, I'll now go back to Dr. Haleema and take this whole telemedicine concept slightly forward. It is generally understood that one of the major advantages of telemedicine is when you have a specialist who can come in and give you an advice. So there is a regular doctor-patient conversation happening, and you actually, how do you bring in a specialist? And he can be part of that, he or she can be part of that call, and telemedicine can make that possible. And I would like to hear from you, Haleema, about how this experience has worked and what things you feel are current challenges in achieving it.
Okay, see, definitely there are portals wherein the specialists are already on board and they're taking the consultations. But it depends on the patient's, what the patient actually asks for. When the patient signs up, basically they have a form which is given to them about the specialty or the choice of the specialty they want to consult. So again, it depends if they're educated well to know about the specialties or difference between GP and general physician, to know what kind of ailments they're suffering from and to know to whom they have to go to. What usually happens is the patients who are not aware of it go in for general physician at the outset. So when a general physician, one of us take the call, talk to the patient, and they analyze the patient and what exactly the patient is suffering from. For example, if a patient comes to any doctor or general physician with possibly a complaint of menorrhagia, something which might require an expertise of a gynecologist, the next thing what we would do in a general platform is to refer. So there are platforms wherein there are already specialists onboarded, and we only have to click a button to refer to the specialty. But sometimes if the doctor here is not aware of what specialty they have to refer to, or if there's anyone available or over there, that becomes a little difficult. At that time, what people usually do, they either refer the patient outside or they refer the patient for an in-person consultation, or basically they would refer to the doctor of the choice whom the physician is aware about. But if we have an onboarded specialist in the platform who the physician is aware about, then usually it is referred to them. But how to improve this is to get all the specialties onboarded in any platform at any given point in time. That would help the consultation to be more streamlined and better. But again, I would re-emphasize that this depends on the patient's knowledge. If the patient is aware that for a headache, I have to go to a neurologist, or I have to go to a general physician or to a cardiologist, the different specialties, then it would make things more easy. But if I'm talking about a patient who is in maybe in somewhere like Orissa, Assam, where they're not aware of things and they don't know what the consultation should look like, they will basically come to a general physician who will basically have to analyze them and then take a call. That should be the ideal way of doing it. Thank you.
Okay. Yeah, what you said is absolutely right. Because we have the larger tech community here, who actually are the solution providers and who can actually have the ability to address those particular pain points while conducting a teleconsultation, I think it would be we would be making, I mean, use of them in the best possible way, when if you with your experience can actually talk to us about what you expect or what you feel is lacking in the current teleconsultation experience that one can look forward to in building solutions. Because the ABDM platform currently gives you a certain standardization. It gives you a patient identifier. It gives you a way to identify a doctor and a facility. But how do you think the current teleconsultation experience can be made better from a technology point of view? What do you think are the lacunae that need to be addressed?
Okay, first and foremost is, as I told you, streamlining the consultation. And then if we can have an AI which can direct the patient to the specialty. For example, if I type in that I have acne, there should be an AI telling me that see a dermatologist. There should be an AI actually guiding me throughout and to tell me where I should go and which specialty I should consult for this particular problem. So if I have something like a headache, which is basically, again, an example I would like to mention again, has different reasons. Headache doesn't really mean that I have to go to a neurologist. Can be a physician, can be so on and so forth. Maybe giving them a differential in an AI would help. Maybe the AI can give us, the reason for headache, and then the patient out there can choose the specialty they would need to go, or kind of add more symptoms to the problem. We can have an AI which can actually give us, give us a additional symptom marker. Headache with dizziness, headache with fever, then it can actually go to the app specialty. Then the doctor can book the consultation, or the patient can book the consultation as so on and so forth. But again, if the patient is not aware of the problem or not aware what exactly they should go in for, it becomes difficult. If the AI can guide them which specialty is needed for them, then it will be more helpful for them.
Okay.
Thank you.
Okay.
Sorry.
I would come back to Dr. Praveen Gedam and to ask him more about the unified health interface and how he thinks what NHA is doing currently can actually help UHI become a pivotal entity or a pivotal framework in proliferating teleconsultation more and more and breaking those silos in terms of a platform dependence that one creates.
Yeah. In the morning, I remember Dr. R.S. Sharma, our CEO, gave example of Orkut, and then we also discussed some other platforms like Amazon and Facebook, which have compartmentalized their own existence within the large internet world. And this does not enable any cross-talking. You cannot send a message from Facebook to WhatsApp, for example, even though they belong to the same company. Now, we have to go the way emails have gone. You can log in from yahoo.com and send your email from yahoo.com to say gmail.com, because there is a common protocol, there is a common language. And this is what we are trying to do in UHI. So we have a protocol, we have certain standards which are accepted by everybody, and these are being developed in consultation with all of you. I urge all of you to go and join the GitHub community of NHA, ABDM and UHI and contribute for this development. So what is going to happen is that a particular solution, particular app is very popular in let us say Nagaland or Manipur, and they want to connect to a doctor in New Delhi or Bangalore where some other app is more prevalent. So that barrier should not be there. They should be speaking freely with each other, and that is what UHI intends to do. Now this is apparently very simple, but kind of a revolutionary or a path breaking concept. To start with, we are breaking silos and we are not enabling development of any silo, and this is what UHI actually intends to do. I would like to in fact hear more from the tech community which is present here, and doctors and others, if they want to give any additional inputs in which this should move forward. I just want to highlight that very soon, in maybe less than a month or so, we will be coming out with a reference application for UHI, which can be used for various types of digital health features like booking, teleconsultation, and paying across platform. And I'm also happy to share that Arogya Setu, the very popular Arogya Setu, very useful Arogya Setu, which I think has kind of the utility was contact tracing, which now is probably not required. So that 220 million mobile apps downloads, we can convert it into something for teleconsultation based on UHI framework, and also for providing several other features like health locker, etc. But mind you, this is going to be a reference app. We encourage the community to innovate and develop further so that this cross-talking and interoperability is actually becomes reality from the dream.
Thank you. In fact, I think taking a cue from the chair, I think I'll open it up for questions and any comments that the participants may have, because this is, and also there are panelists on the joining us remotely also. If you have certain suggestions, I mean, we would be like great to hear. We'd be happy to hear them as well. Dr. Pankaj Sharma, Mr. Sandeep Thote. Mr. Sandeep Thote.
Yes, sir.
I think he's speaking. We can't hear him.
Can you hear me now?
Yes, we can. Yes, absolutely.
Yeah, hi. Good afternoon. I guess. Thanks for involving me. So I just to specific questions that we've seen in the telemedicine platform that people been using as a WhatsApp video call commonly use, and from medical legal perspective, the storage of conversation, especially when it has been done over the electronic, would be important. And I don't think, especially if you look at the private practitioner or otherwise, would have the storage mechanism. And we being also technology provider, we have explored. There are other platforms, open source platform, which can be easily integrated into the telemedicine platform. So even the reference application that is getting developed, I guess recording facility should be available in such platforms. That's my views and comment. Thank you.
Thank you. Mr. Pankaj Sharma or Mr. Pankaj Gupta. We can hear from the yes, please. Can somebody pass on the mic to him?
Hi, my name is Rafiq and I'm representing Srushti Software. This is not a question, it is more like a suggestion, or I'm not sure if the solutions are already available in the market. I'm completely not used telemedicine as such so far. I think what we have to look at is the patient journey when it comes to telemedicine and enhance the patient journey. For example, after the teleconsultation, we can add up a medicine delivery, or we can add up a laboratory, sample collection, something like that. I think that would complete the, that will give more confidence to the patients to go for this service, because ultimately what happens after the telemedicine, he has to anyways go out for medicine or go out for the laboratory or something. So this is my suggestion of enhancing patient journey.
It's already, I'm sorry, it's already there in many platforms. There are many people who are using this particular suggestion which you have already given us, as in getting a lab test done immediately after the consultation and getting the pharmacy, told about the medications, and the medications are delivered home. This end-to-end service is already going on in many private platforms, but getting them in the NHA, I think that would be a great suggestion to do. with the consultation, and following the consultation, if we can get the labs running with us, as well as the pharmacies acting on the medication, that would be a great thing to do. Thank you.
Thank you.
Great. In fact, I would like to go on and add that one of the objectives of the unified health interface is actually to create these kind of additional functionalities. And the beauty or the whole idea is that if you are in a particular platform today, even if there is a probable availability of, let's say, booking a lab test or ordering a medicine, you are only limited to those 1 or 2 labs or medicine providers that particular platform may have empaneled. With UHI, we want to open it up and give the choice to the patient or the user completely to decide which one of the many providers of lab tests or medicines he can use. So that's the whole democratization of providing the service that we are trying to bring about in this. Any other question from the participants? There are some questions
In the chat. Somebody can open them.
Maybe they can open it up. I think some are old questions. There is one question on, is there a standard proposed for a prescription or script after a consult, a teleconsult?
Yes, there is a standard for the same, wherein there are no abbreviations allowed, and the prescription has to be quite authentic, legible, and explained in detail. For example, the name of the medication should be written clearly. Of course, in the digital form, it should type properly, and the dosage should be mentioned, the duration, and after the relation with the meals, like after meals, before meals, everything has to be written in details, and including the possible side effects. During the consultation call itself, we have to streamline the things in such a way that the doctor has to explain the possible side effect of the medicine to the patient in the call, followed by a written caption in the prescription. For example, if I am giving an antihistamine to a driver, he will have to be aware of the sedative aspect of it. If he is not aware of that, then we're going to have a accident, that's for sure. So mention that to him verbally as well as in the prescription. This is very, very important to the format, and it's already in place, and we're making sure it's being followed. Thank you.
May I add something?
Yes, Doctor.
So the Pharmacy Council of India guidelines provides a complete list of items that every prescription should have. So that is one place where it can be referred to in terms of paper format. Under ABDM, the FHIR profile, there is something called prescription record, which has been designed keeping the Pharmacy Council of India guideline in mind, and also the completeness of. So these are the two, what Dr. Haleema is referring to is the clinical side standard, which is there in the PCI guideline. And what I'm telling you from the FHIR side is the technical side structural standard, which also you can follow if when you're developing a system, knowing that it will be compliant to what PCI requires.
Yeah.
Precisely why we would not encourage WhatsApp and Facebook as a consultation medium, because we will not have an authentic thing to look back on, and the prescription issued there would not be following the guidelines, and it would be a very big issue in the medical legal aspect. So any doctor taking a call on a WhatsApp or Facebook, I think please encourage yourself to go in and enroll in the portals and dashboards so that you can have an EMR and EHR to fall back on. Thank you.
Great. I see we have had a couple of more questions in the questions column there. And yeah, physically also we do have one.
Myself, Agam Jain. Should I?
Yes,
yeah.
please.
Agam Jain representing eVital RX. Basically, we are digitizing the pharma supply chain in India with the one of the largest medicine database in India. Would like to add if there would be any APIs to get these pharmacies registered or to be the part of this UHI.
I mean,
Yeah,
yes, Dr.
In fact, when we talk about health facility registry, the facilities certainly include pharmacies. So we will encourage all the brick and mortar pharmacies to join. 1. 2, when we talk about UHI, one of the key software will be softwares which are used in pharmacies, so that people can come to know what is the availability of medicine in nearby pharmacy where he can go, he can see the prices beforehand. And also that also can be ABDM compliant. I mean, whatever prescription is generated can be linked to the ABHA, so that the next doctor's visit, the doctor has access to what the patient has been consuming. So pharmacies are very much part of this whole ecosystem. And in fact, we will be soon reaching out to all of them, 7 lakh plus pharmacies and their software providers, to get them onboarded ASAP.
We do have thousands of such pharmacies KYC'd on our platform, and all are the local pharmacies.
So we can actually look forward to how to utilize the existing databases. One thing which we are very particular about is to ensure that the data is actually very update correct, to ensure that trust element in our registries. But that's a separate discussion we can have separately. And we do take databases separately, not only pharmacies, but databases of drugs. If you see the consultation paper on drug registry, which is on our portal, that also talks about how do we consume existing DBs of drugs. So yes, we want to work with all of you so that the ecosystem gets developed as soon as possible.
Thank you, sir. Thank you very much.
Questions we can take from the chat box.
Let me take one question from the chat box and then I'll come to you. Can you please open this up? There were a couple of questions.
Q&A में click करो.
No, I mean, yeah. Please share your thoughts on ABXML.
Are private, yeah.
So the question is, are private rural telemedicine players allowed to tie up with ASHA or Anganwadi workers?
Of course, yes. In fact, ASHA, Anganwadi workers, why only ASHA, Anganwadi workers? The pharmacies the gentleman spoke about, or a common service center or a panchayat office, they all can double up as a telemedicine kiosk, whether you can go walk up to and see which doctor you want to get connected to, do teleconsultation, pay whatever facilitation charges. And then, so I think these are the new avenues which can come up to make, help bridge this gap of demand and supply in this whole healthcare ecosystem.
The next question is, what is a more feasible option for doctors to use an electronic signature for a prescription post a teleconsult? Maybe I myself should answer that question. In fact, we want to do something better than a signature. One of the objectives, and in fact, one of the projects that we are currently working in NHA as part of ABDM is using verifiable credentials. So as you all know, we have what we call an HPR, a health professional registry, which is a verified list of health professionals. And one of the objectives of having it and having a teleconsultation provider to be part of this is also to provide him with this verifiable credential, which he can actually sign after every consultation. The advantage of this verifiable credential is, unlike a typical digital signature that actually simply gives you that tick and which is digitally signed, this gives you a QR code, which then can be easily scanned by any other entity to actually check who was the doctor who gave the prescription, to whom it was given, and also certain other basic information. So this is a work that we are currently doing, and this is what we hope to be one of the drivers of teleconsultation, and also to bring in people to the HPR and take it to the next level from purely digital signature to more to a world of verifiable credentials.
There was one interesting question in the Q&A chat.
Can you go back to the Q&A chat?
About what is being done for training, etc.,
Yes.
of use of these solutions. Now, yes, we are doing whatever is possible, for example, development of videos, brochures. But the key is that in the digital world, when we have thousands of solutions in the market, how do we have thousands of brochures? In fact, you think of various apps which are used even by so-called digitally illiterate people. So people know very well how to use Facebook, WhatsApp, and even the advanced features within that. In Paytm, for example, all those payment apps, they kicked off very fast. The key here is to ensure that the solutions are developed in such a way they are extremely easy to use. User should be like intuitive enough to guide the users. And that is where the role of private sector comes. I mean, we are not very well known, the government side, for that particular aspect of software development. And one more reason why we say, okay, we will restrict ourselves to core platforms. The ultimate success will come only when we have solutions which are extremely easy to use, including by doctors. They should use as less mouse clicks as possible, and even for the patients, so that the success that we saw in fintech and social media and such other sectors is replicated in the area of digital health. Having said that, obviously this has to be supplemented by various other initiatives of teaching. So we are having kind of developing the learning management systems for Ashas and Anganwadi workers, etc. But that's probably not sustainable enough. The sustainable one will be the one where solutions itself are very easy to use.
We can take a question from.
Good evening, everyone. Kaustubh Chatterjee from NASSCOM. Is there any provision for UHI to integrate with remote patient monitoring devices, point of care diagnostic devices, and integrated analytics to enable real-time decision making?
Okay. See, I think one point needs to be made clear here is that UHI is a gateway. It actually enables a user to discover a provider. Now, coming to the point where talking about device-based data to be made available. See, the FHIR profiles that Mr. Gaur Sunder talked about, there are 7 different profiles trying to capture different forms of data. And one of the profiles is what we call a wellness record. So the wellness record actually is able to capture things such as steps taken and other what you call your heartbeat rate and certain other things that devices can actually capture. So if the application that you are using, ultimately it is going to create data, create data out of it. If the data is created and transformed into this profile, the wellness record profile or other object, it is then automatically available for any other device which is ABDM compliant or any other system that is ABDM compliant to consume it. So let's say you have a watch. This watch is capturing my heartbeat, my let's say it is also capturing my blood sugar levels. If that data is then transformed into this wellness record profile, then it is automatically available for any other entity that is participating on ABDM. So let's say I have a PHR app. I can actually then see that data in my PHR app because it is in that format that I can read. So UHI is about bringing point A, the provider and the patient together by providing this search, discover, book, confirm, avail a service, and then fulfillment. And the other building blocks that we have built as part of ABDM is actually how to make sure this data actually moves. So that is why those 3 interoperability, the things that I talked about, the transportation is already solved. SMTP, HTTP, etc. is done. The structured thing is what the FHIR is bringing. The semantics thing is being brought by the SNOMED city and other standards. So these are being taken, these standards have been taken by making sure that ABDM actually is compliant or actually they become the core of this ABDM implementation. And every building block actually subscribes to this kind of thing. So any device, any entity that is creating a health record, if it is creating in one of these, and let's say these 7 of them are not sufficient, if you want an 8th one or one of these need to be extended, it can be done. Dr. Sunder can add more if he wants.
Yes, so basically the current, we started with about only 5 records, now we are about 7. And if need be, we'll go on adding. In fact, when in the morning health claim exchange was being talked about, there's going to be another set of a couple of records which will be catering to this entire workflow related to health claim. If I can hazard a kind of demystifying, the ABHA ID does not preclude anyone from using any other ID for their internal purposes. What Kiranji is correctly pointing out is that it is the one which uniquely identifies a patient within the ecosystem of ABDM. If, for example, a device manufacturer, for example, my watch manufacturer, if it wants to remember me by my Google ID, it's pretty fine. But the moment it becomes a health information provider, there will be a map of my Abha ID with my email ID in their system, using which whenever a query is made from ABDM system, they'll be able to correctly identify my records from the system and set it. So there is no need and necessity that you have to use Abha ID. It is up to you, the way you design the system. But the moment you start interacting with ABDM, there is nothing but Abha ID to identify a particular person. Rest all IDs are essentially mapped in some or the other systems internally. So it's not one or the other game. It's essentially, it's an ecosystem which enables and make it all works together.
I think we have one question from.
If I can ask a quick question
Yes,
to the
yes,
panelists. Hi, good afternoon, Anune from Japaigo. One thing that we're particularly sure of, just like UPI has increased choice, increased availability, and improved penetrance, I think for all of us, UHI will be perhaps more of the same in the long run. It will promote competition, it'll increase choice, it'll potentially drive down costs and improve outcomes of care as well. However, there's one difference that I'd like to point out and raise a question to the panelists. Healthcare is, in effect, a very experiential transaction that happens, right? And so in order to promote choice, in order to give people the option of what they want to choose, which pharmacy they want to order from, or which physician, or which service they want to consume, would there be any metadata that would be added on top of just the physician's profile or the teleconsultation service or the pharmacy availability from where you want to order on the UHI itself? Things like ratings, things like cost elements, etc. What would those metadata elements essentially look like?
Yeah, I will try to explain. It's a very complicated thing to explain. Actually, let me try. But first and foremost, we are trying to have as less data as possible. So when I talk about data about doctors and facilities, we are following the principle of minimalism. As what is required for the patient is language that the doctor speaks, the specialty, the education, number of years of experience, and then whatever in addition doctor wants to show about himself. If he wants to put on his photograph, other details, etc. So having said that, now in UHI, you will come across 10,000 GPs even within a city of Bangalore. How do you select one? That's a key question. So ratings, yes, we discussed. We would like to capture it or not is a debatable issue, because how do you rate a doctor whether the treatment given by him is a correct one or not when he has more knowledge and much more knowledge about the medical science than you yourself? So that rating of a doctor is not as straightforward as one can see for a rating of objects on Amazon. That is one. Secondly, then there are certain issues which are certainly amenable to rating. For example, whether doctor makes me wait for a long time in the digital waiting room, whether he speaks properly, politely, or rudely. So these are the different aspects which we feel can be rated. Then on Amazon or Flipkart, you cannot rate Amazon itself. You can rate a object, but what about rating of a platform? So that is one more additional layer. And also rating needs to be done with absolute caution. You have to ensure, because it's a very sensitive, you can spoil somebody's profession by one bad rating, right? So maybe not allowing anonymized ratings, or after verifying the credentials of somebody who wants to rate, giving an opportunity of countering that rating immediately below that. Some app providers are following the model in which they just mask out the clinical part of rating, which I just discussed, so that that is not encouraged. So there are a lot of things which nuances which needs to be considered when we talk about the health domain. it's not as straightforward as the rating on other in other domains.
Sorry, I would just like to add one thing. Rating as per the recent NMC guidelines has been removed. So no one can rate a doctor in any platform. This is the latest guideline which has come up by the National Medical Council, and they have totally stopped any kind of ratings for doctors. It is
Metadata.
metadata, yeah. That depends.
Yeah, so maybe you can use that metadata. For example, I want to see a doctor who has least waiting time. And maybe, but then what we call health service provider applications, HSPA is the jargon we have created in addition to what so many we discussed. So we can have all such kind of additional features coming up, running on the top of the base layers that we have created. And in fact, it is here that we would like the industry to come forward with these value added additional features. As far as we are concerned, we will limit ourselves to whatever we are capturing in the registries and the core basic functionalities that this particular Abha is linked with these 15 or 15 different health records. We don't know what is there in those health records. So that is the basic data that we will have with ourselves, and we will not have more than that. But nothing prevents you all from having whatever is legally permissible on the top of the data that we keep, so that you can improve your own user experiences that you offer, so that you can also maybe gain some advantage on your competitors.
If I may,
Yeah.
just
Please go ahead.
I will pose it the same from a different point of view. Should ABDM even be platform where something like this can be done? For example, fine, I as a patient may want some rating about doctor. What if doctors start asking about rating on patients? Where do we end up then? So these are more of philosophical and in terms of metadata, I understand your point of view, and what Dr. Gedam is correctly saying is that there will be a lot of data and analyticable data capture, which can be then data analyzed to build something like this. But I don't think, and I was there when the National Digital Health Blueprint was being written, a lot of the things were discounted in the sense that we should not do it, okay, rather than what we should do it. Because the problem with building an ecosystem and a platform is that sooner or later we may want everything to be either done by government, or we want everything to be built on top of it, whether right or wrong. So whether something like this system should be built or not, whether it should be part of ABDM or not, are more bigger question than the mere metadata part of it. That is very easy. That can be done.
Yeah. Yes, there was one question.
Quick question on my side. We spoke about different coding systems because these are the building blocks for the entire digital health, LOINC or SNOMED, ICD. Is there a regulatory roadmap for it so that the government of India will back it and say that, yeah, all healthcare providers must use it like we see it in the Western economies?
I'd like Dr. Gedam to take this question, or Dr. Gaur.
Yes, actually, starting from 2013 onwards, Ministry of Health has already mandated these standards to be used in health systems. 2013, this was there. 2016, it became more of a clear guideline in terms of what is to be used where. And when ABDM and at that time National Digital Health Mission was formed, the mission director codified this into a set of rules for ABDM system, that ABDM systems must use this standard. So much of the standard in terms of FHIR, in terms of consent management standard, in terms of SNOMED, in terms of ICD, in terms of LOINC, it already set and much of what is being done already follows it. So in terms of regulatory guideline, Government of India has decided long time ago that these, many of these standards are free, and some of these where membership is required, government has become member. It is for currently and foreseeable future freely available for anybody to use. So much of the ABDM system has been brought up with the idea that there will be open standards, and these standards will be available and then usable by any other person. the amount of effort, this investment that is going on from the government side into making sure these standards find their rightful place in their ecosystem is most probably indicative of the regulatory approach to the whole idea of the standard. I think.
It's easier to integrate these standards from technical standpoint of view, and which we encourage our integrators to do, and most of them are doing it. But the problem is of adoption.
Yes.
So what do we do if the doctor is presented a kind of that on the user interface ends up typing a free text, DM with HT with MI with this very typical medical jargon, which is understood only by doctors, and computers will get they will not make sense out of it.
Adoption from a
So
medical
adoption is a
perspective.
challenge. Then you will have a huge heavy OPD setups where doctors will use paper. Somebody will scan it and upload it. Even worse. So it's not even it's image PDF basically. So that is going to be challenged. So while we encourage, we certify, we will start certifying the products as fire compliant and whatever, all those things. But when it comes to adoption, it's going to be a challenge. We understand that. And for some time, we see that the unstructured, non-machine readable data will continue to flow into the system, but that should not stop us from going forward. I remember 20 years ago, I used to receive email from some gentleman who used to write letters, scan it and send it on email. And sometimes WhatsApp images also, particularly in vernacular languages, when the Indic languages were not available on the WhatsApp keypad, that used to happen. But I think we have started that journey, and let us complete it as soon as possible.
I think we'll have time for one question, and then we'll have some remarks from the chair.
Hello, sir. This is Maitli from Software Freedom Law Center, India. I had one question with respect to the verification process of these different entities that register with the registry. So you have a lot of registries ranging from health facility registry, health professionals registry. So I wanted to know if NHA is going to verify all the professionals, all the hospitals, all the apps, everybody who's being registered, because more often it actually happens. So we had on a panel, when one of them said that AI algorithms will be used to, really diagnose and see what are the different symptoms, what could be the outputs. But so we did do a little research on this, but most of the health apps do not consult the doctors. They don't have a medical literature backing whatever the suggestions they're giving. So my main question is, does NHA verify all of these people who are, registering themselves with ABDM?
Yeah, Dr. Gedam can take.
So when it comes to healthcare professionals, the element of trust is very important. So government, it is either local state government or the concerned state medical council or nursing council or whatever council. They verify the doctor is a doctor before that particular digital identity is made available through APIs for other solution providers. So that answer is yes. There are many attributes which are verifiable. For example, the degree of a doctor. And then there are certain attributes which are not verifiable. For example, somebody claiming to have done diploma in some hospital in UK, that cannot be verified by an entity, government agency in India. So there we have developed an option of verified attribute and self-declared attribute, which can be seen after hovering a mouse on that eye symbol. When it comes to facilities, the level of verification is slightly lower. The bar of verification is slightly lower because the person who actually matters in facility is a healthcare professional who is verified. So for facilities, we allow a self-declared facility which can be verified. And in fact, this is one more opportunity for companies to come up. If any company wants to have this kind of additional business, if I can say so, to go out and verify the entities, give their star ratings, and add their tags on top of this data, they are most welcome to do so. We see this ecosystem again developing. And the third registry is Registry of Persons. We change the architecture a bit, and every single Abha going forward is verified by using Aadhaar. So when I say that this is Praveen Gedam's Abha, it is actually Praveen Gedam because he is verified by using Aadhaar. And for legal reasons, since we can't make Aadhaar mandatory, we have also started giving alternative KYCs for those who are not willing to use Aadhaar for the purpose of verifying the Abha. So to answer that question, tech companies can forget the whatever legalities which come with verification or lack of it of a doctor, and they can solely rely on the NHA, NHAs, and just go ahead with their innovation rather than focusing on the verification of doctors.
Verification actually is very easy. NMC has their own, there is a button there in the NMC website. You just open it. They will just mention the doctor's name. You'll have the whole entity of the doctor. It's as easy as that these days. So verification is definitely done for every doctor before onboarding in any way. NHA, private, government sector, any place. Without verification, no one is there in the telemedicine line. No doctor is allowed to practice without verifying the credentials beforehand. And with NMC in place, it's really very easy to do that. Thank you.
Great. I think the question and answers, I think, have been very useful. In fact, there was one very important point that was raised by one of the participants as to how NHA or the ecosystem developed by NHA is going to help startups in utilizing the building blocks that we are building, and how they will be useful for, let's say, some clinical validations or testing out certain things or testing out their applications themselves. And one of the important things that is being done at NHA is trying to come up with a public health dashboard. I request Dr. Praveen Gedam to speak about it a little bit, so that the developer community is more aware of it.
So this public health dashboard is one of the new tracks that we have started developing. It is yet to be made available. But the idea is, again, going back to that question on metadata and data also, it is somehow connected with that, is that we are generating data in silos. We say that it will remain in a federated architecture system, so no common repository. But again, having so much of data, 140 crore people and everybody going to a doctor at least 4 times in a year, it's kind of crime not to use this digital data for public health intervention. So what we have thought is we will have a platform where anonymized data only will be pulled, only selected indicators which are of relevance. No, we don't want to pull the data about how much premium somebody is paying for health insurance, but yeah, what kind of drugs are being prescribed, what is the kind of diagnosis is being done, the demographic pattern. And using these 10 odd indicators, we can then come out with data visualization, which we can make available through APIs if somebody wants to improvise upon it, about the epidemiological patterns in a particular state over the period of time, pattern of drug consumption, including their side effects, what is the trend in antimicrobial resistance, so that the doctor understands which antibiotic to prescribe or not to prescribe in that particular area for that particular infection, and also infra and HR related data. So in X district, what are the hospitals available with which specialty, and how does the local disease pattern look like, so that I can make the correct decision about which hospital and which kind of specialty to invest in that particular area. So these are all the opportunities which come up, and again I focus at the base of it will be the confidentiality, secrecy and privacy. So that's why we say that we will ingest it in an anonymized fashion, and that's the new track that we have started, which should help, and then it will be available to everybody. Researchers, I remember to reach out to 30, 40, 100 patients, researchers have to really slog, go and take consent and do whatnot. So that really slows down the speed of real research. Hopefully this will make it very easier.
Thank you, sir. I see one or two hands raised, but I think we are already approved, right? And we can talk to once we are down, once we come down of dais. So I thank the panel. I thank the chair, Dr. Praveen Gedam, Mr. Gaur, Sunder, Dr. Haleema, and also the panelists who have joined us virtually. And this was a very useful discussion. And once again, I'd like to reiterate that what is being done under ABDM by NHA is a collective effort. And like the CEO mentioned today, we are building the highways, we are building the roads, but you are the ones who are going to run the traffic on it. So welcome once again, be a part of us, come and explore what we are doing and play with the sandbox, play with the reference applications that we are developing, and talk to us. And we would like to learn more from you and improve our systems even further. And I'd like to thank NASSCOM for organizing this wonderful conclave. And I think with that, with the permission of the chair, we'll bring this session to a conclusion.
Thank you.
The session to conclusion, I will request Praveen sir to present mementos to Gaur, Sunder sir and Haleema ma'am. I will also request Kiran Gopal sir to present it to Praveen sir. I take the liberty to present to Kiran.
Thank you so much, all of you. Also, so we had the innovation booths by 3 of our very dear startups. So first, I would like to invite on stage Dr. Surajit Nandi from Raksa Health. Dr. Meenal Muni, product head from Artivatic. Thank you. Okay. And Mr. Anurag Pandey from Ala Care. Oh, that's okay. Please. It's okay. Come on, everyone would like to help you. Hello, everyone. A very good afternoon to one and all present here. Hello, everyone.